game-changing discussions on the big ideas that shape our thinking. This is One2one.
Dupe Elebute-Odunsi is co-founder and CEO of the Marcelle Ruth Cancer Centre and founder of the Women in Healthcare Network. She's a consultant hemato-oncologist, trained and worked extensively in some of the UK's most prestigious centres of excellence, including St George's Hospital, King's College London, and the Royal Marsden. She's also my guest on the show today. Dr. Elebute-Odunsi, welcome to One2one.
Thank you very much for having me.
A real pleasure. A real pleasure. So, Dr. Dupe Elebute-Odunsi, you are a consultant hemato-oncologist. You are co-founder of Marcelle Ruth Cancer Centre and also founder of the Women in Healthcare Network. You are widely celebrated for building the first comprehensive cancer centre in Nigeria. Dr. Odunsi, you graduated in 1986 from the College of Medicine, University of Lagos. You underwent postgraduate education, medical education in internal hemato-oncology with various centres in London, including St George's, the Royal Marsden, no less, St Bartholomew's Hospital. I was there very briefly myself. I met the great Professor J.S.P. Lumley.
Oh my God, yes.
Who I remember saying to me at one time, we all learned by embarrassment. He said to me,
True, very true. I must use that actually. Trainees, yes.
I've never forgotten it.
Yeah.
You obtained a prestigious fellowship from the Leukemia Research Fund and obtained a Doctor in Medicine degree for your efforts at the University of London and for your outstanding performance. So after 30 years of service and practice in the UK, you made the bold decision, after having served the NHS for so long, to embark upon this journey to Nigeria. So what precisely would you say inspired this extremely bold move, really? And perhaps you could come on to it later. Well, what exactly does it mean for it to be said of you that you've built the first comprehensive cancer specialist centre in Nigeria?
From my perspective, I know people always ask me that question. I think they asked both my husband and I the question because I co-founded Marcelle Ruth with my husband, Bolaji Odunsi, who is in the finance industry. So I think for me, it was the realization around, I think, my 50th birthday that having gone to medical school here and been involved with the medical services here because my parents obviously worked both in the public sector. My father was provost of the College of Medicine. They taught in the medical school, postgraduate students, and then they started the Lagoon hospitals because they had this vision that actually the private sector was what was going to help to drive excellent standards of care in the Nigeria health sector. So I think I was sort of piggybacking on that and seeing things as I came and went. And then later on, it became something that was quite important for me. But it was more about coming to retire in Nigeria. That was the plan. That was the plan. But plans made and other roads followed to come and spend the last few years of my working career and to try and, I think, give back. And I don't think we say it in a sort of funny sort of way. It's just about coming to contribute to what is going on here. And of course, for those of us who lived abroad for so long, you also have this sort of feeling that you have maybe not given your children an opportunity to grow up here and to know Nigeria and to really understand where they're from. Whereas we have this positive experience of having gone to school here and then and lived abroad. So it was really about that. To be honest, if anybody, fast forwarding now to the hospital will be 5 years in December. But of course, building the hospital took 2 years, and then because it was around COVID, so it took a bit longer than we thought. So we've been in that transition now for about 8 years, but actually the hospital will be 5 years. But never in my wildest dreams, so I'm not going to lie, has this story panned out the way I thought it was going to be. When I first started looking at a venue for a clinic, because what it was going to be, I was looking for a 2-bedroom flat in Oniru, you know.
You're a long way from that now.
Yeah, a long way away from that. I mean, that's where getting my husband involved, the story changed the whole dynamics. But I think also, and I always refer to it, I think that when you embark on a journey that I think it truly is designed by God, or whatever higher being you believe in, then you realize that actually what you think you're doing and where you might get to might be two totally different stories.
Out of your hands.
And one of the deciding or changing things for me in particular, I was going to a dinner party at a girlfriend's in London. And my husband wasn't around and his wife wasn't there. We sat together at this dinner table and he was asking what I did, and I said I was a doctor. And, people always sort of sit up and then you say you're a consultant, in a teaching hospital. And so this conversation continued because usually people either stop and ask you a medical question, a personal thing. They want you to, I have a cough. What do I do? That kind of thing. But he seemed quite interested. And I was going on about wanting to come back to Nigeria and get involved with the health sector. And he didn't say too much. He listened to me, and as I was leaving, he gave me his card and he said, come and see me sometime. And I looked at it, and he was a gentleman called Chris Starlin, who was the head of life sciences for KPMG worldwide. And so we did go and see him, and he was the one who said, something, actually, there's a massive gap in your country. You're a trained hematologist, oncologist, and in particular, there is a dearth of infrastructure, particularly with radiotherapy machines and so on. I really think you should consider doing something more impactful rather than just something to retire into. And that's how the story, so the combination of him with Bolaji, who now did a lot of research, and from a business point of view, felt that it was something that would be quite useful to consider doing.
Sure.
And that's how the story sort of started.
Yes.
Now, when you ask me about what's it been like being back, so first of all, I think if we spoke to about 100 people and said we were coming to do this and actually moving back and you were actually going to build, I know you're laughing already, right? Everybody's going, are you sure about this? You're not just coming to live in Nigeria, you're bringing your money to come and invest in Nigeria. But, again, I think we just came with a totally different mindset.
Absolutely.
We hadn't lived here for years. So I think all the negativity, yes, we heard it, but somehow it bounced off us. We just got on with it, right? And even though it wasn't an easy journey, and there are a number of stories to be told, particularly in construction, and the difficulties thereof, and bringing the radiotherapy machine to the country and so on. But it happened. It kept going. There was never a situation where it was a complete stop. Yes, it was difficult, but I mean, when you've worked in the NHS like you did, when you've done postgraduate training, none of it has ever been easy, right? This is a different type of difficult.
Absolutely.
And we just sort of got on with it.
Yes.
But I do remember the first week after we opened, and a number of patients came in and they said, I'm not sure I'm going to come back here because you have this cancer in the name of your hospital. I'm not sure I want to, come back. And I called Bolaji and I said, maybe we should change the name of the hospital because there's this stigma about cancer. And he looked at me and he said, well, okay, you brought a radiotherapy machine into the country, one of only 10 when there should be like 1,000. And you want to say this is not a cancer hospital, you're on your own. Hey, but yeah, looking back now, we're almost 5 years and we've seen almost 5,000 patients at Marcelle Ruth. And in particular, I think what really strikes me is that we've seen about 200 children with cancers at Marcelle Ruth. And it's just been, you realize that when people say there's a need, they really was a need. There is a
There
need.
is.
There still remains a need. But the need had to be done, I think, in the way that we've done it, to provide all the aspects of care for patients on the one site, which is what you're referring to as this comprehensive one-stop shop. And that is what every single day when I see a new patient arrives, particularly when they come from other parts of the country or indeed from Lagos, and the patient's coming back like with your practice from abroad, and they describe, so this gentleman I saw a few days ago had been to a teaching hospital, then he went to a private hospital, then he went to Turkey, then he came back, then he did this, and and you're dizzy. Just think about a patient who's been told they have cancer, and then this is the process they have to go through. I mean, nobody's holding them together. They're falling to pieces. And he was actually in tears during this consultation. So being able to provide everything that they need, from the screening to the investigations, to the imaging, to the theaters if they need surgery, to the inpatient beds, to the chemotherapy, and the radiotherapy, all in one place, I think is really been really an honor, to be honest, to be able to deliver this care. Yes.
An honor indeed.
Yes.
So you've touched on several things in the course of this conversation already. But can I ask you first, what exactly inspired the name Marcelle Ruth?
Oh, okay. So, I mean, the answer is easy, but the journey wasn't. So for about 2 years, I was trying to curate a name and doing a lot of research, and my father, now of blessed memory, I remember, was very involved because he reads a lot, and we were Latin names and Greek names and the Greek god of health and all sorts of things and everything, but Yoruba names, and none of it really sort of gelled. And then when I was doing my research, I realized that quite a lot of cancer hospitals, even the Mayo, named either after people who had cancer, their cancer journey, or a family member, but the family are now sort of sponsoring the whole hospital. And so I was thinking to myself, well, who do I know who? And my mother-in-law, Marcelle Ruth Odunsi, had actually had a cancer journey from which she actually passed away. And then, of course, from my personal point of view, in gratitude to my husband, who actually has been my main investor to date, I thought it was actually the perfect name in her memory, and also to say thank you to him. But I think it's also important because although she was English and obviously her father was Nigerian, but she actually came to Nigeria in her 20s and lived here for all her life. She was a teacher, and she was a history teacher. I think she taught in Queen's School, Ibadan, first of all. Yes.
My wife went there.
Oh, there you go. There you go. And then she taught history at Igbobi College. And
My brother went there.
There you go. And she became the vice principal of Igbobi College. And it's quite interesting because lots of patients who come to the hospital suddenly say, oh my gosh, is this the same Mrs. Odunsi who was our vice principal? And then when the government started the government girls' colleges years ago, she was the first principal of government college, Agege, who celebrated 50 years recently and did something in her honor. And I always like to say that because, people, when you say she was English, people think she was so Nigerian, because she spent, most of her life here. And the memory of her students and so on, of her. And I feel from my point of view, it's great that we could be able to honor her name in this way.
Yeah.
Yeah.
I mean, a perfect tribute,
Yeah.
really, to someone who has contributed so much.
Absolutely.
No, well done. We've had on this program earlier Professor Kingsley Ekweme,
Oh, yes.
the esteemed geological and robotics surgeon, and we talked in that conversation
Yes.
about the fact that there's so much late presentation of disease. About 80%, for example, of cancer patients come at an advanced or late stage. Can you talk to me a bit about the burden of cancer disease in this country and perhaps across Africa? I know you mentioned earlier that you've seen about 200 children,
Yes.
for example.
So
Please.
yes, I mean that the 200 children is a bit of a surprise to me. The almost 5,000 patients again in this period again is quite a lot really. But obviously we're all sort of like a tertiary referral center, so we're seeing patients from all over the country and patients coming back from abroad. But there definitely seems to be a change, I think, in the presentation of cancers in younger people. So we've got quite a lot of young patients in their like 30s, 20s, 30s, 30-year-olds with colorectal cancers, 30-year-olds with breast cancer. So we seem to be seeing a younger population of people with cancers. We seem to have an increasing number of patients with cancers, and we can talk about the reasons why we think that could be. And of course, in our environment, we cannot avoid talking about, and I know that you had Mr. Masha recently, but what we put in our mouths and whether our foods are grown in areas where there is no, the pesticides and so on, and the environmental causes or that can predispose to cancers. Obviously, we don't smoke that much in our environment, but we are seeing an increasing number of lung cancers, particularly in women. So at Marcelle Ruth, we are collecting data every day, and I can tell you already that we've seen about 12 to 14 young women with lung cancer, which is quite unusual in a population where we don't smoke. So that brings to mind what is going on with the pollution. So, there's a lot of generator use. There's, cars are not regulated in terms of the emission of fumes and so on. So I think we in this part of the world can't avoid the discussion about environmental effects. However, we all know, and more so now because we do the tests, that there's genetic predisposition to cancers. And again, just information that we are seeing a higher proportion of our patients with positive family histories of cancer. But you touch on on a point that I'm very, very passionate about. And then this is about this late detection and late presentation of cancers, which is in today's medicine really sad because it's a waste that doesn't need to be. And therefore, every time that I'm asked to speak or that I have the opportunity, I do say that if you don't remember anything else from this program, please do remember that early detection does save lives. Cancer can be cured because, again, in our environment, people think, no, it's a death sentence. It is not. And we pick up early stage cancers, stage 1, 2, even early stage 3 cancers. We can treat these patients and cure them for life. So that's a message that needs to be emphasized. I will say, though, we're beginning to see the change already. So this is 3-4 years. Quite a significant number of our patients are presenting early. That is for sure. And so I'm hoping that happens next, and I've been very fortunate to be appointed to 2 national task forces, one on cervical cancer elimination and the other one to do with looking at cancer control for the country. I think that now it's time to use our voice in a national platform, so that it's not just about the patients who can afford to have all this done in the private sector. We have to have screening programs for the wider population. This is where we need to be. And they said there's a lot of work going on now, and there's been a lot of support from the government as well to try and get this done. But we're really behind the curve, so we need to really get this started now. And because it does make the difference. In most countries now in the world, cervical cancer is eliminated through HPV vaccination and so on. So that's where we need to be.
Absolutely, and the fact that you've touched on screening programs, it immediately it elevates the problem to a national level. So, but we're not talking really about wellness when we talk about screening. It's something the government has to get involved with.
And to be honest, it's everybody's right to be informed, because that's one of the issues. It's people are not aware They don't, and I don't mean even educated people are not aware, right? I had the opportunity a few weeks ago to give a talk at quite a big church. I mean, I didn't know they were that big, to be honest, when I was invited to speak, because a number of my patients had come from Abuja to us. And I remember giving this talk, and afterwards, they're very, very highly educated people, but the questions they were asking, and also the view of cancer. And I said, you do realize that most people that get cancer haven't done anything wrong. In fact, it's as much a shock to them. I said, so why would you have a work colleague who has cancer, who's unwell, who's going through treatment, and it's not the right thing for you to find out how they're doing, or make sure that they go for their appointments? Because sometimes these people can't even tell people at work that they've got cancer, because they don't want to talk about it, because there's this stigma, which delays their treatment, which reduces the risk of a chance of getting better. And you just see the light bulb.
Yeah.
And people suddenly realize that actually we're not helping, our fellow colleagues or family members when we could be. So those are the messages I think we need to drive.
Absolutely.
Removing this stigma, and also pushing the early detection story. And not just early detection, because of course there's detection, but talking about, it's so sad, the people that cannot then access treatment.
Yeah.
And of course that's a bigger topic.
Absolutely.
In our world right now.
And we are going to,
in our sector.
we're going to come to that.
Yeah.
So obviously we need to become a better educated society.
Absolutely.
You have just described what is a societal and in fact a socioeconomic problem, the burden of disease that exists.
Yeah.
But permit me to read out something you said. You've said, my big hope is for everyone to have access to healthcare. For people to walk into a hospital and trust and know that they will get the right diagnosis and treatment with compassion. So obviously,
I said that.
you have said many things.
It does ring out of something I would say.
And I'm quoting directly.
True.
Absolutely, quoting directly from the pumpkin.
Yeah.
Absolutely. So obviously you're speaking to the issue, the problem of access.
Yes.
But of course, directly linked with the question of access is affordability. Now, affordability, of course, is a big part of that access. It's fair to say, would you bet that you own and operate a first-class medical facility.
Thank you.
In what must be described, I think, as very much a still developing economy.
Yeah.
That's what Nigeria is.
Absolutely.
Are you confident that your services at Marcelle Ruth are, given the size and the scale of problem we described,
Yes.
are you confident, are you reasonably confident that these services are affordable, accessible, really to the average Nigerian? And if not, how do you propose that we collectively as a society aim to bridge that gap?
Yeah. And it's a very important question. And I think that, for most of us who are sitting in the private sector, healthcare sector in Nigeria, must every day have this sort of niggling that although we know we're doing well by actually even being here and providing this care, which wasn't easily available, the majority of the patients would have to leave the country to go abroad, in particular to India, South Africa, that are far away. And there's the additional costs of their flights, their accommodation, before you even talk about the foreign exchange that they need to pay for their care. Now, there are two things to say. One is that actually it's the majority of the patients that come to a place like Marcelle Ruth are not patients who can afford this care out of their pocket. Okay, so a lot of them are actually being supported or sponsored, either by companies, their employers, some by government of bodies, some by NGOs. A lot of family members, and I mean, in our world, of course, if people run a GoFundMe campaign to say they have cancer, they're more likely to get people to help them. So that is, access, but they can still come to the hospital and they can still get there.
Sure.
And I am glad, I don't make no apologies, that we're able to provide that care. But in particular, because we're able to give it to them in one place and look after them properly, which is the other thing about access to care. But I always say that I don't feel that I came back just to look after the 1% of the 1%, although the majority of our patients are not that 1%, they're just that they're funded by that system. And so looking at it from a wider social point of view, it would be my dream, and just what you read out, that everybody should be able to access care. But I think that is the government's job. And that's where, so for example, I'm sure that even if these services could be provided in the public hospitals, you and I would give up a few days a week to go and help those places deliver the care. You and I would go and help to ensure that the medical students and the postgraduate students are taught.
Absolutely.
Because I know you've done a lot in medical education, right? We would do that for nothing, right?
Absolutely.
But we can't go and make every public hospital what it's supposed to be. And whatever expertise you bring to the table in healthcare, you also need the infrastructure. You can't do it without the two. We in the same way that I think there have been a number of infrastructure bills across Nigeria, particularly in healthcare, that are empty tomorrow because they've not been staffed, right? Or be staffed by the right level of technical abilities. And that is where, from a government point of view, it's that they need the talk needs to stop, and we really need action needs to happen on both sides. So infrastructure, yes, but training and making sure that the expertise is there to look after these patients, and that's what we need, really.
Absolutely. And so the existential problem that confronts us in healthcare is funding, isn't it? We are practicing really an ethical minefield.
Yes.
If you're poor in Nigeria, you're far more likely to suffer adverse health outcomes because health follows a social gradient.
Yes.
Dr. Elebute-Odunsi, it has been an absolute pleasure.
I've really enjoyed this.
Talking to you on the One2one show. Thank you so very much. Most insightful.
Thank you.
Thank you.
Thank you very much.